dives to around 100 feet in depth, 25 meters in depth, is the 80 to 100 foot range, to collect pearls, actually. Obviously, pearls have great value, and this allows them to collect pearls at the depths that pearls are encountered. They do so, they wear white. This is kind of their traditional garb, which is supposed to ward off sharks. They dive to great depths, they collect their pearls, and then they come up on their rope again. They don't use the weighted stone like the Greeks do, but there's a similar tradition in the Korean peninsula called Haenyeo. They were more, again, they were female, a group of females. This tradition is still in practice today, mostly among females, and they do it more for collecting food. The Sama, or the Bajau, is a number of nomadic coastal ethnic groups that live in these raised huts. They essentially live off the water, like I mentioned. It's a subsistence lifestyle, certainly much more primitive, a much more primitive lifestyle. It's unfortunate they're actually they're considered kind of second-class citizens, from what I have heard and read, in Indonesia, because they're kind of considered, sort of just primitive people, but they are, their existence is almost entirely seaborne. They're born on the sea, they're born on boats, they're born on, these raised huts that they're able to build with driftwood, whatever they're able to find. And their existence really is totally dependent on their ability to dive and collect food at depth. So, a little bit of foreshadowing here. What differences make the Bajau well suited to their lifestyle? Well, perhaps there is such a difference. And then here we get, into the competitive freediving. So this is, taking the sport of breath hold diving or breath hold, underwater breath hold, and kind of taking it and making it a competitive endeavor. There is a sanctioning body, the Association for the International Development of Apnea, and they certify records. They hold competitions both at the local, regional, national, and even international level. So, if you, and not that I am really advising any of you to get into it at this level of competition, but if you, anyone who's trying to dive to great depths or hold their breath for a significant amount of time and wants to get a world record out of it would go through these people. There's a number of different categories that there is competition in. There's competition in world records as well. There's the no limit category, which that is, you can do whatever you want. You can use any weight to get you down. You can use a balloon, you can blow a balloon to get you up if you want. You can have your buddy pull you up with a rope if you want. The only rules are you cannot have any sort of breathing apparatus. Variable weight is similar to the Scandala Petra that we talked about. You can have a weight pull you down and you can let go of it and shoot back up to the surface if you want. Constant weight is just wearing a weight belt. You can wear fins in that category. Constant weight without fins is obviously you wear a weight belt and you're unable to wear fins. Free immersion is kind of the purest form of the sport, is just a person in a wetsuit or a Speedo, go as deep as you can, come up without passing out. And obviously, I suppose it goes without saying, but the rules are, in order to qualify, you have to not die and not pass out in any of these categories. Dynamic with fins, so this is just swimming, holding your breath, swimming underwater in a pool, same without fins. And then the static apnea is just how long can you hold your breath by taking a deep breath and diving, putting your head underneath the water. And so here, these are the records that we have currently for the men. There's also women's categories as well. They're generally a little bit smaller than men's are, but here you can see 214 meters. So that's, on the order of, I think, 700 or so feet of depth for the no limit category for men. So that's pretty deep. I don't know how familiar everyone in the audience is with depths and diving and free diving, but that's pretty impressive, 214 meters. 146 with the variable weight category, 130 meters, the constant weight category. So obviously as the restrictions go up, the depths go down a little bit. But these are some pretty impressive depths that people are able to hold their breath. far, far beyond what anyone thought would be possible in the 60s when kind of the physiology of free diving and physiology of breath hold and breath hold diving was sort of first being explored in a real scientific fashion. People actually thought that the depths of human exposure, human depth the limits of human depth exposure would be on the order of 60 or so meters. So here you can see we've blown that out of the water. There's some reasons that people thought that I'll tell you about here shortly. Spearfishing, I don't know how many of you guys hang out with friends around here, and when I say here, I mean in South Florida, who have had boats. I know we have a national audience today, who have boats, go out fishing, go down to the Keys, go diving. Spearfishing super common, super popular. Go to any dock around here, you'll see a bunch of people on their way in and out going spearfishing, talking about what they got, this fish, that fish. Again, Instagram is a big driver of this. Everyone wants to get the sweet Instagram video of themselves popping a grouper at, whatever, 60 feet to show off to their friends or whatever. So that's it really. As far as the background of breath hold diving. So the physiology of the breath hold, again, this is not particularly challenging to think about. We breathe oxygen, we breathe because we need oxygen, and we produce CO2. So the physiology of the breath hold really is that's kind of your main the main tenet is oxygen consumption and CO2 production. So those things are really what's going to limit your ability to perform breath hold. So the storage capacity, you have oxygen storage capacity, and that consists of your hemoglobin, your myoglobin, the oxygen that's held in your lung, and then just dissolved oxygen in the plasma, which forms a small portion of the circulating oxygen compared to hemoglobin-bound oxygen. And then CO2 production. So obviously we're producing CO2. Different levels of CO2 are produced per unit of oxygen stored or per unit of oxygen consumed. If you remember, that's the respiratory exchange ratio. That's diet dependent and caloric intake dependent. And so what dictates what an individual can tolerate? Well, it's kind of an individual characteristic. My break point may be at, I may lose consciousness at a arterial or alveolar partial pressure of oxygen of 50, and maybe Shilpi can go down to 20 without losing consciousness. It's just sort of a personal characteristic, as is the hypercapnic tolerance. So we have a drive to breathe at a certain partial pressure of CO2 in our blood, a certain arterial partial pressure of CO2. At a certain point, it'll get intolerable, and your diaphragm will take over, and you will breathe, regardless of a voluntary attempt to limit that. So that's your break point. That's called your conventional breaking point, and that's actually trained. First of all, it's individual. Every individual starts off with a different breaking point, and that's trainable. You can train yourself to tolerate higher levels of CO2 with repeated exposure. So the breath hold. What happens when you take a deep breath and hold it? So we've all done this, just kind of playing around, trying to see how long we can hold our breath. So what happens? So the breath hold is divided into two phases, kind of in the literature and among people who do research on this. There's the easygoing phase and the struggle phase. So the easygoing phase, yes, I'm holding my breath, but I'm not struggling. And that's defined, it's actually defined by a voluntarily closed glottis. And our intrathoracic pressure at that time is stable. So there's no diaphragmatic contraction. We're able to, take a deep breath in, hold it, and we're not having any movement here. And that's kind of, a lot of people, when they say this is how long they can hold their breath, they're really kind of referring to the easygoing phase, because once you hit the next stage, which is the end of the easygoing phase, which is the physiologic breaking point, you will start into the second phase, which is the struggle phase. So again, everyone's physiologic breaking point is at a different level of PCO2. Per studies, they've found average is around 46. So that's not very high when you think about what a normal ABG CO2 level is between 36 and 40. The body doesn't like to tolerate a very much hypercapnia, and that's good. As you remember, our baroreceptors, the primary respiratory mechanism to increase or decrease our respiratory drive is PCO2. So you just get a little bit out of that zone and you get to the physiologic breaking point where you then move into the struggle phase. And what the struggle phase is high intensity, involuntary, high frequency diaphragmatic spasms. So you are trying to not breathe and keep your glottis closed, but there's brain circuitry that is below your cortex that is telling your diaphragm and to a lesser extent your intercostal muscles to breathe. You need to breathe. My CO2 is too high. Interestingly, again, the physiologic breaking point is trainable with repeated exposure. Up to 90 millimeters of mercury has been described in these extreme breath hold divers. And so at the end of the struggle phase, you reach what's called the conventional breaking point. And that is, there's no additional way of halting your body, preventing your body from taking a breath in. And so you're going to take a breath in. The glottis opens and your diaphragm contracts, and in comes whatever is around you, whether you're underwater and that's water, or whether you're holding your breath up on the surface, or in a physiology lab. So that's the conventional breaking point. So this is a graph illustrating kind of what I was just talking about. I think it's a very good, interesting graphical way to look at it. So this is just the intrathoracic pressure recorded in a volunteer through a manometer, an intrathoracic manometer. And here you can see these squiggles. Here is the patient, or the research subject, I guess patient, taking deep breath in, deep breath out as they get ready for their breath hold. And so here you can see the relatively flat intrathoracic pressure. That's the easy phase. So there's maybe a little dip right there of negative intrathoracic pressure, maybe a little diaphragmatic spasm at that time. But they're able to hold it for this certain period of time. Then here you reach the physiologic breaking point. You can see their diaphragm is starting to contract. They're getting into negative pressure as they're able to hold the glottis closed against it. But then as soon as they reach their conventional breaking point, they can't keep their glottis closed any longer, and they take that inhalation. This is research performed by Dr. Chagate, who's one of the big experts out there, and does a lot of very interesting research in the field. So that's what happens when we hold our breath. So what happens when we take someone who's holding their breath and put them into the water? Just kind of as by way of a brief physics reminder, as you increase depth in the water, you're obviously increasing pressure. People who were able to listen to Dr. Covington's lecture a couple of weeks ago, you remember that 10 meters of depth in the ocean or 33 feet of seawater actually doubles the pressure that's experienced by the body. And that's what we call 2 atmospheres absolute. So that's 1 atmosphere is the absolute atmospheric pressure at the surface. If you double it, you get to 2 atmospheres absolute. So what happens what happens just at the level of the lung when we start adding pressure into the equation? So if you remember Boyle's law, P1V1 equals P2V2. Anyone in hyperbaric medicine is big on Boyle's law. The simple way to think about it is like a balloon that you're putting underneath the water. It's going to shrink to essentially half the size, or at twice the pressure, it's going to shrink to half the size. But the partial pressure of the gases within the alveolus are going to be twice what they were at the surface. So here's kind of a simple calculation that's done that I did here of just how that would work in a simple equation like that. You can see the partial pressure of oxygen would increase, but also the partial pressure of CO2 experienced in the alveolus would increase as well. Which begs the question, I mean, does that really happen? Would humans immediately become hypercarbic upon diving at depth just because of the partial pressure of CO2 going up? And the reality is, no, it's way more complex than that. The human body is way more complex, particularly in a setting of immersion, in ways that are very interesting. And actually, kind of some people conjectured that humans went through a primarily aquatic evolutionary phase as a result of our interesting physiologic adaptations that allow us to deal with prolonged immersion very well. It is conserved among many diving mammals. We're not the only people who have these adaptations, obviously, but we have them pretty well. So just as an example of how that simple equation was wrong, this is actually simulated hyperbaric breath hold exposure to show what actually happens at the level of the alveolus when we dive. When we hold our breath and are exposed to high pressure. So you can see the partial pressure of oxygen experienced does increase, but the CO2 actually doesn't. And then so this is, as you can see, this is going down in the water. This is the level of oxygen in the alveolus. It goes down a little bit as the oxygen is consumed while you're at depth, and that's your oxygen level dropping. And then as you ascend, obviously it goes down as well as the pressure is released. So, but the CO2, interestingly, really doesn't rise very much at all. So why does that happen? What happens to cause that? This is just another interesting similar study, and actually in immersion. This is ABGs showing the arterial partial pressures of oxygen among 6 very highly trained individuals at surface, at depth, and then again at surface. And as we would expect, the partial pressure actually rises in 4 of the individuals, but actually in 2 of the individuals, the partial pressure of oxygen didn't rise at all. It actually stayed stable. So clearly there's a lot more going on in the human at immersion at depth than can be explained by kind of simple physics. So enter the mammalian diving reflex, which really has a lot to do with it. Again, this is conserved among a lot of mammals to varying degrees among different animals, and depending how much time they actually spend in the water. But it's a complex series of responses that actually serve to increase your underwater apneic duration. The primary ones that work are cardiac and peripheral vascular, but there's a couple other changes as well that allow us to be more well suited to diving than can be explained kind of by simple physics. So this was first observed by Dr. Paul Baer, who's did a lot of research in pressure back in the early 1900s. He was forcibly submersing ducks and noticed a dramatic bradycardia. So there's another entrance in the annals of research that will never again be performed. He apparently was just taking ducks and sticking them in the water and essentially drowning them. But he noticed, and it was conjectured that the oxygen was being conserved for the more essential organs at depth. Additionally, they conjectured a switch to anaerobic metabolism in the more ischemia-resistant tissues, that being, obviously the muscles and the soft tissues that will produce lactic acid, but then allow lactic acid to wash out and switch back to aerobic metabolism when respiration resumes. So what exactly does this do? So the cardiovascular response to immersion. So that's a big one. So there is a bradycardia, as Paul Baer noted. It's mediated by the vagus nerve. So this is something that we are able to exploit, actually, if you're working in the emergency department and you have somebody who's, let's say, is in a supraventricular tachycardia. This is the same physiology that we exploit in those certain cases by using that ice pack to the face or whatever to convert their SVT. That's actually exploiting the mammalian diving reflex, something that evolutionarily is present to allow us to dive deeper and for longer. It happens to a differing extent depending on the temperature of the immersion. So the response is the most pronounced in very cold water to the face. To a lesser extent, let's say cold water to the face without immersion. To a lesser extent, warm immersion. But diving into a freezing cold water is the worst, or not the worst, but the most pronounced in terms of causing this change. So the heart rate decreases. Conversely, the stroke volume actually increases, and so you have a heart that's beating slower, but with an increased stroke volume. There's actually debate in the literature as to what the net effect on the cardiac output is, but it seems to be more studies point toward a decreased cardiac output with immersion, with cold immersion, as a result of this mammalian diving reflex. Some studies have shown an increase as a result of that increased cardiac output. So what do you see during diving? You can see cardiac arrhythmias actually as a result of this. Mostly what you would expect with a high vagal tone. So that's, bradyarrhythmias, heart blocks, et cetera. But, there's never been a documented diving mediated bradycardia that causes any sort of symptom. So the patients, the subjects being studied will have this pronounced bradycardia, but won't feel anything wrong. They won't feel their heart beating irregular. And just as an example of this is three trained divers immersed in water at, I think is 25 centigrade water, so relatively cold. You can see their pre-dive EKG tracing there on the left is nice normal sinus rhythm. They jump into the water, and here you can see, a couplet and a prolonged pause, another couplet, and then another prolonged pause. I think the RR interval here is like 8 seconds or something like that. This one you can see he jumps in, and I don't even, I look at EKGs essentially for a living. I don't even know how you describe that. Certainly isn't normal sinus rhythm. It's not anything I really recognize. This bottom one here, you can see, this maybe is a narrow QRS. I don't know what this little squiggle is, but, this is someone who's asymptomatic, who's perfusing their vital organs. So that's interestingly, the irregular beats are hemodynamically effective. The only arrhythmia that has not been observed, and this is one of my favorite facts about breath hold diving, the only arrhythmia not observed in relation to breath hold diving is ventricular fibrillation. So obviously that VFib is a rhythm that's not compatible with life. So, pretty much everything else you can think of, VTAC, AFib, SVT, you name it, somebody has been documented in the research literature as having had this arrhythmia associated with diving into the water asymptomatically with stable perfusion and everything like that. So the peripheral vascular effects also play into this diving reflex. Immersion, just simple immersion in the water, actually causes redistribution of blood centrally, and that's kind of what this image here is trying to show. You can see their IVC and femoral veins are nice and plump on the left, which is standing dry. As soon as you're immersed in water, the external pressure experienced by the body causes a redistribution of lower venous blood from the lower half of the body into the central circulation. You can see here, this is representing the pulmonary vasculature. It plumps up as that blood is redistributed into the core, into the thorax. And that's actually, it's the equivalent of around a 700 cc's of blood transfusion, as all that blood is redistributed into the thorax. So that's something to think about. Obviously, let's say you got someone with CHF who wants to go swimming in a pool. Maybe that's not the best thing for them. But this is part of what allows the stroke volume to increase so much, as you are immersed in water. So that's the venous side. On the arterial side, there's a brisk arterial constriction as well, causing central redistribution of blood with diving. And this is conserved across all mammals as well. And just as a great example of that, this is from the 60s, but this is a lower extremity angiogram of a wettled seal, which is a deep diving animal, showing here's the aorta breaking into the various femoral branches here. This is in the dry, and you can see a very brisk and pronounced vasoconstriction upon diving. So that allows that blood to go from, as I mentioned earlier, the ischemia-resistant tissues with good anaerobic metabolism, like the muscles, and be conserved for the heart and the brain and the more vital organs. Additionally, one other trick the body has up its sleeve is splenic contraction. So with breath hold diving, the spleen actually has been shown to contract with repetitive diving. So if you think about the spleen, it's a big, basically blood-containing organ. That's why surgeons never want to operate on it, because it's full of blood. And if you're starting at the surface, it should all be oxygenated hemoglobin, oxyhemoglobin. So you got this big spleen here that's essentially doing nothing with all that blood. So with repeated diving, the spleen actually contracts, and studies have shown that, at least in humans, we're sort of wimps on the diving stage, as it were, compared with other mammals, but we still can have a decrease in 19% of our splenic volume with repetitive diving. And that, the suggestion obviously is that is liberating that oxygenated hemoglobin from the spleen and allowing it to participate in circulation. And again, we've actually seen that in studies as well among the Hyenyeo divers in Korea. Their hematocrit actually increases throughout the course of a dive, which further supports the idea that the spleen contracts, oxygenated blood can go from the spleen and participate in circulation and keeping our vital organs alive. Going back to our friends the Bajau in Indonesia and Malaysia, they've actually been found to have a greater per kilogram splenic volume than similar to more terrestrial counterparts, which obviously the conjecture is that increases their ability to dive and have an increased underwater time at depth. So the research that found that out actually made it into Cell. So it was a pretty important, pretty interesting study, and it also made it onto I think Real Sports with Brian Gumbel, as well as Sports Illustrated. So anyway, so what's going on with the lungs? Let's think about the lungs a little bit. So again, going back to that simple model, the lungs are a gas-containing organ. It should contract on descent. It should go per Boyle's law. You increase the pressure, you get smaller lungs as the balloon, as it were, is shrinking. But let's think about this for a second. The average total lung capacity, let's say, of an adult male, 6 liters. So that's how much air you can put into your lungs and your respiratory tract with a deep breath in. And the residual volume, which is the amount of volume that is left and you totally exhale as much as possible, is only 1.2 liters. So using Boyle's law, we can do a quick mental math calculation to see what should be the limit of depth exposure, because at that point your lungs can't contract anymore. They're as small as they can be according to our surface level pulmonary function test. And that comes up to be, using these numbers, around 132 feet. we just finished talking about how people have far blasted past those depths with exposures. So how are we doing this? How are the lungs able to do this? So far beyond residual volume. So it turns out that the diaphragm actually can extrude up into the chest wall. The lungs themselves actually collapse. There is collapse of the trachea, if you recall from anatomy. The posterior portion of the trachea is soft, is soft tissue. It's not firm. So you can have kind of anterior not herniation, but anterior displacement and collapse of the trachea, really to nothing. You can have redistribution of blood into the pulmonary vasculature as well, and even into the trachea. It's been documented that there's been vocal cord edema and vocal cord hemorrhage as a result of this blood redistributing, the negative pressure exerted by the lungs on deep descent. Additionally, the alveoli themselves can just collapse as well, and that there's actually thought that by collapsing, the alveoli are actually preventing hypoxia as the partial pressure of oxygen in the lungs is decreased, it's absorbed, those alveoli can then collapse. So there's not a negative concentration gradient to pull blood out of oxygen out of the blood into the lungs, which can happen, but by collapsing the lungs, that actually prevents that from happening. So all this negative pressure on the lungs as you go deeper can actually cause what's called a lung squeeze. So if you think about it, you go deeper and deeper and deeper. The lungs are sucking in, getting smaller. It's sucking fluid in, it's sucking blood in. Your hernia, your diaphragm has herniated up into the chest as much as it possibly can. If you still keep going deeper and deeper and deeper, you can get increasing transpulmonary pressure. And that can cause damage to the alveolus. It can cause transudation of just simple fluids, similar to CHF, similar to what happens with CHF. It can actually cause alveolar rupture. It can cause pulmonary hemorrhage. So very frequently, people doing deep dives, multiple repetitive deep dives, will come up and they'll be coughing frothy sputum. They can actually be coughing up blood from pulmonary hemorrhage, and it can actually increase your risk for arterial gas embolism. So that's called a lung squeeze. Super common. If you ever get onto any of the free diving boards, spearboard, anything like that, you'll hear people talking about the lung squeeze. So let's say we are a competitive free diver, or we're just a super serious spear fisherman or something like that. What do we do? What can we do to increase our dive duration? There's a number of things you can do. You can do what's called lung packing. You can use your oropharynx to try to take as deep a breath as possible and pack more and more air in there using your mouth, essentially. Can we do it? Is there such thing as a free lunch? No, it's really dangerous. Actually, it increases your risk of pulmonary barotrauma. You can hyperventilate. What does that do? You breathe a lot. The more you breathe, the lower your CO2 gets. And if you remember, the CO2 is what dictates your physiologic and your conventional breaking point. So that's what's going to tell you, shoot, I got to stop chasing this grouper and I got to get up to the surface for air. Well, if you breathe a lot and lower your CO2, you're starting lower, you're going to get more time underneath the water. But, as I'll show you here in a second, that actually is pretty dangerous as well, because it increases your risk of hypoxia of ascent. The ketogenic diet, if you go back to that alveolar gas equation, if you change your respiratory exchange ratio around, you can produce less CO2 per unit of oxygen consumed. You can increase your dive duration that way, actually. And these are all tricks that these competitive people are using at their own peril, unfortunately. So just as an example, this is kind of how I like to think about this, the risk of hyperventilation. This is just the arterial oxygen and arterial CO2 level, let's say, of a dive. So you descend as the pressure increases, the arterial oxygen goes up. At depth, it goes down slowly as you're consuming some oxygen, swimming around, chasing fish, trying to grab some lobster. And then you ascend as the pressure is relieved. The arterial oxygen, which reflects the alveolar oxygen concentration, is decreased as the pressure is relieved. So it goes up, and here's your smiley face. This is your happy diver. This, this is your CO2, which is slowly building. You hit the break point. It says, oh, shoot, I got to go up. I need to get some air. So you go up, and your oxygen level kind of comes up, or goes down, but does not drop to a dangerous level as you hit that break point. So let's say you pre-breathe, you do a hyperventilation before you start with a CO2 of 20 now. As you are going down, your oxygen does the same thing. As you go down at depth, and you're producing CO2 as you're swimming around, but now you still haven't hit the break point with your CO2 down here, and you can stay longer. So up here, you can see your at depth time will increase. But what happens to your oxygen? You're still consuming oxygen at that time. Let's say you do hit the break point here. Oh no, I got to go up. I got to get up for air. Your CO2 crosses that break point. You're going to go up to try to get some air, and you're ascending. And as you ascend, your arterial oxygen, which again reflects the alveolar oxygen concentration, is decreasing, but you may cross that threshold where you actually black out. So that's the risk. That's the hypoxia of ascent, or shallow water blackout. And that's the sad diver, because he blacked out, and maybe he hasn't had a buddy watching him the whole time. And there's, if you follow the news or search spearfishing fatality, freediving fatality, this happens, unfortunately, I wouldn't say a lot, but at least a couple times a year, you'll hear a story. Some kid spear diving out of here or there. Unfortunately, has a shallow water blackout, and there are fatalities as a result of it. Other risks of breath hold diving: you can get pulmonary barotrauma and arterial gas embolism just the same as you could with scuba diving. It's been described as shallow as 3 feet of ascent. Anywhere you can, the lungs are like a balloon. They can pop really at any change in pressure. It doesn't have to be a great depth. The risks of this are exacerbated by glossopharyngeal insufflation. You can get other just regular barotrauma. You can get sinus squeeze. You can get ear squeeze, goggle squeeze, etc. The same maladies that affect you with scuba diving. To avoid this, some of the elite competitive people actually inhale as much seawater as they can prior to competition, so that their sinuses fill up with water. So that's no longer an airspace that will expand and contract. So then they don't have to waste time clearing their ears and their sinuses. They also use these fluid-filled goggles, which are kind of just like little fluid, like contact lenses, and the rest of the goggle is filled with fluid, so that it allows them to see, but also that's not an air-containing space as they're competing. The risks, again, hypoxia of ascent, as I mentioned. That's why it's really dangerous to do this hyperventilation prior to diving. What about DCS and breath hold diving? We talked about DCS a few weeks ago with Dr. Covington, associated with scuba diving, being down at a long enough period that you on-gas enough nitrogen that as you decompress, it can create bubbles. Well, yeah, actually, it's very common, not very common in breath hold diving, but it's common enough that it has a name, Taravana, among the Polynesian people. And that's in the Tuamotu language. It means to fall crazily. In Polynesia, the divers would do 40 to 60 tons of repetitive deep dives every day, trying to pick up food, etc. This happened often enough that they created their own term for what is now described as DCS related to deep breath hold diving. So yeah, it certainly can happen. It was enough of a risk that when Herbert Nitsch did his world record dive, which I'll show you here in a second, he planned a decompression stop similar to how you would plan in deep scuba diving. You have to build in decompression stops to allow that nitrogen to off gas from your tissues and decrease your risk for decompression sickness. So that's what he did the first time. Unfortunately, the second time he was trying a 240-meter dive, he actually got DCS and had to be transferred to a hyperbaric chamber in Athens and be treated after he went down to 240 meters and came up too quickly and got DCS. So he didn't get to keep that record. So he still stands at 217 meters. So this is just an example.
Dr.
This is his actual.
Just letting you know, we're about 2 minutes away from 6, just to keep an eye on time.
I'm wrapping it up. I feel like I've been talking a lot, so I apologize. But this is his actual dive profile. This is an equalization stop right here. This is him clearing his nose. This is him going way down. And to do this deep of a dive, he's using actually a weighted sled to get him down. So this here is him doing decompression. This stands as the deepest any human has ever held their breath in underwater. So just in closing, this is kind of interesting. I find this very interesting. This is him actually doing his world record dive, 214 meters, 700 feet. So here's his weighted sled. You can see his fluidized goggles on. This is, to make him more fluid dynamic as he goes down. This air bottle, so per the rules, you cannot carry obviously any sort of supplemental air. So what he does in order to be able to clear his sinuses, he's got a Coke bottle that apparently is some big endorsement deal with Coke, but really any bottle would work. He blows some air out, and he can then take it into his oropharynx and equalize his sinuses and his middle ears. So that's just one of the more creative product placements that I've ever seen. So here he is. He's just going way down really quickly on this weighted sled, all the way down, and he gets to eventually 214 meters. There's Coca-Cola quite prominently advertised. He disconnects himself from the weights, and then they turn on the assist device, and it just rockets him straight back up to the surface. And there it is. It's a pulley system in this case, just pulling him straight up. Obviously, he would have to be exhaling to decrease his risk of pulmonary barotrauma and arterial gas embolism, because, as his lungs have contracted, they're now going to be expanding. And he, for some reason, disconnects himself from the sled because he wants to hang out for a little bit. And here shortly, you'll see him just kind of stop and linger on the wire, and that's him doing his decompression stop. So that's in order to minimize his risk of DCS. So here he is just kind of hanging out, allowing the nitrogen to leave his body, leave his tissues, and equilibrate with the partial pressure of nitrogen in his lungs. So, here we're at about 4 minutes. He's been holding his breath. And very slowly he makes his way up to the surface, purposefully going slowly in order to decrease his risk of DCS, which unfortunately did affect him on his subsequent record attempt to 240 meters. So, and here he is reaching the surface with his new world record. So that's a brief look at free diving. I hope you guys found it interesting, and I love to think about it and to talk about it and to read about it. I'm happy to take any questions if anyone has anything. If I didn't totally bore you to death with a lot of ABG talk, unfortunately that is kind of the stuff that gets us excited, but I know is a little bit dry at times. And I apologize, I was a little late. I wanted to add in more cool pictures, which would maybe have made it a little more exciting and visually stimulating to look at. But, like I said, I was running from the ED to get here. This is the Duke Hyperbaric Chamber. It's the largest facility, the largest civilian hyperbaric facility in the world. Is where I got to spend fellowship year, and it's pretty fun. So anyone with any questions?
Yeah, Dr. Sayers, thank you so much for that awesome presentation. First of all, I'm going to speak on behalf of everybody to say thank you for running from the ED and giving us this
Yeah.
awesome talk. We did have a bunch of questions submitted. We'll try and go through some of them. I'll try and read them off just for time's sake, if that's okay. So we had a question from Shannon from Temple, and she asked, why can some people hold their breath until they pass out before they reach their conventional breaking point?
It all has to do, and that's why, for me, being a graphical person, I did that little, silly animation with all the PowerPoint animations. It all has to do with where your oxygen, so you're consuming oxygen, where your arterial oxygen level is as it's, slowly trickling down, while your CO2 is building. If you can tolerate more CO2, you will get to the point of blacking out due to hypoxia before you'll reach your conventional breaking point. So let's say you have a very high tolerance for hypercarbia, but a very low tolerance for hypoxia. you'll be able to hold your breath until your partial pressure of oxygen gets to low enough for you to pass out without ever having triggered your hypercarbic breaking point. So it's, to me, it just in my head, it's a graph. It's where the graphs cross. You got one line, which is your breaking point, your CO2, your hypercarbic limit, and then you've got, and what happens when you reach that limit is an involuntary breath. You also have the line. Every individual has the line, which is their hypoxic limit. And unfortunately, what happens there is that you black out, and if that happens underwater, obviously that's life-threatening. As is, the hypercarbic breaking point, but that could potentially also trigger you to seek air at the surface or something like that. So yeah, really, it just has to do with where your individual tolerance for hypercarbia and hypoxia lie, and how quickly you're producing each of those. Each producing CO2 and consuming O2. And another interesting thing is these vary day to day. Our oxygen, our resting VO2, varies day to day depending on our, obviously our core body temperature. If you exercise the day before, you're consuming more oxygen as your body is more metabolically active. Let's say you went out and you just had a bunch of fries and your respiratory exchange ratio is more toward that 1.2 number. You're going to be producing more CO2 per unit of oxygen consumed. So, this stuff, even within an individual, can vary from day to day, actually.
Great.
Thank you.
And then we actually had I think, an interesting question from Sarah Jacobson from BCom. And she asked, would you suspect that the arrhythmias that you showed are observed in avalanche snow burials initially?
Ooh, good question. I would assume, I'm sure, yeah. Just because it's a similar exposure. I don't know that answer directly, but I mean, there would be no reason that they wouldn't. I mean, this is the temporary vagatonic tone, as I mentioned, is why when you're in the ED and someone has an SVT, you put a bag of ice on their face. So yeah, I mean, I think that very likely is possible. I don't know that answer though. I don't have I've never read a paper or seen that in a textbook, but yeah, I think very likely.
And then we had a question, how are ABGs performed at depth?
So arterial line was placed, and essentially a three-way stopcock was added on there. That's why they could only do the kind of the three values. Yeah, and there was a diver. So that paper actually was done by one of my attendings at Duke. There's a 40-meter pool in Italy that some rich guy just built because he likes freediving. I think it's called Deep Joy in Padua or something. I forget exactly where in Italy it is, but it's just basically a straight down shaft that's filled with water, and it only exists so that freediving dorks can go practice there. And pretty much everyone in Europe who's into freediving goes there to practice and to train. Do their breath holding, whatever. So Dr. Moon and an Italian researcher actually put A-lines into pretty elite competition freedivers. Put a guy down at the bottom of the pool on scuba who could just aspirate from the three-way stopcock. They didn't even disconnect it there. The subject went down. They aspirated the blood, which obviously reflects their arterial blood gas at that time. Closed the stopcock, it's in that syringe, and then the subject swims straight back up to the surface. So just as an example of kind of how the hyperbarics world, and the dive medicine world we're not the same as cancer, where you have these 50,000 patient studies and stuff like that. When that was done, it was actually considered a pretty impressive feat to actually get that reel of data. So it was only 6 patients. They're repeating it with a bigger series of people, but yeah, that's how they did it.
Wow. I think we'll do one more question since we're coming up on 6:10. If
Mhm.
anybody has any other ones, feel free to send them to me and I'll get Dr. Sayers to answer them for you. So this last question, can apneic exercises and recovery breathing be used as a mechanism for treating chronic respiratory conditions like sleep apnea?
Good question. I think theoretically, yeah. I mean, I don't know that. I wish I had read a little more. That's a very good question. But potentially, right? Because we think of the, chronic CO2 retainers as having lost their CO2 sensitivity. So I imagine that the same thing is going on in chronically hypercarbic people, and people with chronic respiratory conditions. Yeah, I think very likely.
Great. So with that, we're coming up on 6:10, and I don't want to keep anybody too
Yeah.
late on this evening. I know Dr. Sayers just got back from work. Thank you so much for coming and giving this talk to everybody.
Of course, yeah.
Much appreciated. Everybody, thank you for coming. As always, we have a talk next week, so I hope to see you guys there and basically every week after that. If you have any questions, feel free to email me. Otherwise, have a wonderful evening, everybody, and see you guys later.
And Shilpa, just while everyone's here, any questions, comments, please do feel free to give my contact information to anyone who wants to reach out, whether it's about, this talk specifically about hyperbaric medicine in general, about what I do. I'm currently working down at Mercy for hyperbarics as well. So yeah, happy to help out if I can, if anyone has any questions.
Amazing. Yep. So if you guys want the contact, you got it. I'll send it over. So thank you, everybody, and have a good evening.
Thanks.
Bye.